Alright, so in our previous lecture we were talking about what would happen to the various body compartment fluid volumes as a result of osmolarity change. So we have talked about vomiting, diarrhea, we have talked about an infusion of sodium chloride, we have talked about mineralocorticoid problem where we have gotten less aldosterone and so sodium is lost. We have talked about the diuretics. So now we're going to talk about two important things. One is sweating and the other one is ADH. So let's quickly see sweating, what happens in sweating. So a person, normally the questions come as a person is lost in the desert for 3 days and then he's found and he has not been able to drink anything, but he has been sweating. What's going to be his status? So the thing to note is that sweat is hypotonic. It's 99% water and then remaining is the solutes. So sweat is hypotonic. What that means is that when a person is sweating, so again it's not ECF, it's the it's not ICF, it is the ECF. So when a person is sweating, so let's say these are the sweat drops, when the person sweats he loses hypotonic solution. What that means is more water goes out and we are left with what? Of course. So more water has gone out, so I can say that this much volume of water is removed. Now because equal number of solutes did not go out, equal proportion of solutes did not go out, solute concentration, relative solute concentration is increased in here. So I would say osmolarity in the ECF has increased. So the size of ECF has shrunk, volume has shrunk, but osmolarity has increased. Why? Because a proportionate amount of solutes are not thrown out. Okay? Now we have gotten more solutes over here. What's going to happen? Water from ICF is going to move. Correct? Because the water is more over here. So when the water is going to move from here, so let's say this chunk of water moved all the way here. That would try to restore this water volume a little bit. So end result is this is going to expand a little bit and this is going to shrink. And then as it expands, the osmolarity is going to come down a little bit, but the osmolarity over here is going to go up a little bit as well. Correct? So when everything is settled, when we are at equilibrium, we would have both compartments shrunk and osmolarity increased. So that is the result of sweating. Normally we only lose about 100 milliliter of sweat per day, but in strenuous exercises, in continuous exercises, a person can lose up to 5 liters of sweat. Similarly, if a person is not drinking water and is sweating, or a person is lost in a desert, as is the example many times, then he would be sweating. So please remember, whenever there is an example that the person has been lost in desert for 2 days or 3 days, what they mean is that there was heat, he was losing fluids or sweat, and then he was not having enough water to hydrate himself. So this is that situation. One more situation which is really important, that is, so before we go to that, what kind of fluid dynamic is this? So this is hyperosmolar dehydration. Dehydration means shrinkage of the compartment fluid volume. Hyperosmolar mean increased osmolarity. This is hyperosmolar dehydration. Okay, so let's talk about antidiuretic hormone, ADH. So ADH, as the name says, antidiuretic hormone, the function of the ADH is really to act here on the collecting tubule cells, and what it does is when ADH comes and acts here, it causes the manufacturing of aquaporins, which are protein channels which allow the water to move into the cell. So remember, water can actually move into the cell just in general by osmosis, but when we put the aquaporins, these are big channels. These are like big pipes which you insert in the water, in the cell membrane, and the water would just come gushing in, and from there it would go back into the blood. So really, as the name says, antidiuretic hormone, the function is it is anti to diuresis. What that means is it is anti to increase the amount of water going out in the urine. So whenever you have ADH, that ADH is responsible to pick the water back up. So we throw the water in the kidney and that water is taken back up. A lot of that water is taken back up in the early parts of the convoluted tubule. This portion is really related to the concentration of the urine. So again, this is not a renal lecture right now, but our next lectures are renal. We would talk about these things more in detail. But when the ADH acts over here and it pulls the water back, this water which is pulled out is really not the water conservation, but it is for the urine concentration. So in any case, ADH higher level or lower level can cause very interesting fluid dynamics as well. So let's see for a second. We have syndrome of inappropriate ADH. We have SIADH, syndrome of inappropriate ADH. What that means is that antidiuretic hormone is more than it should be. Okay, so be careful what's going to happen. More ADH is going to pull more water back. This water in a normal person was going to go out in the urine, but in this patient who has SIADH, that water is retained. Is that water also accompanied by sodium or chloride? Is that an equal proportion of solute and the water going back? No, this is free water. This water is not accompanied by sodium. Normally when we take the water back, sodium and chloride and those potassium and those things are taken back and the water follows them. So there is an equal proportion of water and the solutes. But over here, sodium is not following this thing. Although urea does follow in this area, but urea is not something which would stay out in the ECF. Urea is going to equilibrate in the whole compartments very quickly, so that has no bearing on the osmolarity. So water is going to be taken back up. So imagine what we are doing is through the renal system, we are attacking the kidneys with the ADH, which then is causing more water to be added back to the extracellular fluid or the blood vessels. It starts in the blood vessel, then it equilibrates in the extracellular fluid. Then if there is any concentration change, then the ICF will be affected as well. Please remember, start from the blood vessels, then go to the interstitium, then see what happens to the ICF. Okay, so the water has come back into the blood vessel. So can I say that the ECF volume is increased? Good. Okay. Did we also establish that when this water is taken back up, we are not picking up the solutes with it? So if we are not picking up the solutes, do you think we'll maintain the same osmolarity? No, osmolarity is going to go down. So I should say that as a result of inappropriate ADH and more water coming back in the ECF, the relative solute concentration is going to reduce. Okay, now what? If the solute concentration here is reduced, that means there is more water concentration here as compared to here, because osmolarity in this compartment is more. So water is going to move from here to here, right? From greater concentration to the lower concentration. Correct? So when the water starts moving, the osmolarity is going to start coming down, and this compartment is going to expand. Right? So both compartments have expanded and osmolarity has come down. What kind of an expansion is this? This is hypoosmolar overhydration. This is hypoosmolar overhydration. Right? And this is caused by the syndrome of inappropriate ADH. Anything which would increase water, for example, I start drinking a lot of water. I just sit down here and I say, okay, fine, I'm going to keep drinking water. This happens, people do silly things like that. So if I start drinking water, so instead of the water coming from the kidney, water is going to start coming from my GIT. What is that going to do? If that water doesn't have the appropriate sodium, chloride, potassium and other things in it, the proportion of the solutes is not correct, then I would be drinking hypotonic solution. That solution would come in, increase the ECF. Start from the blood vessel, it would increase the volume here, that would increase the volume in the ECF, the osmolarity would go down. Why? Because I drank pure water, I did not take sodium with it, or chloride with it, or other things. That would then have the same effect. So it is not necessary that just SiADH would do it. If a person takes too much water, that would do it. If a person is infused with the hypotonic solution, that would do the same situation, same thing as well. Okay, so now let's talk about if there is more ADH. So if there is more ADH, what's going to happen? ADH's job is to, syndrome of inappropriate ADH is more ADH. If there is less ADH, then what would happen? ADH's job is to preserve water. So water is going to start going out, but we are not keeping the solutes in the same proportion. So what would happen is extra amount, so we're talking about less ADH, so more water would go out. This is called diabetes insipidus. Diabetes insipidus is that a person cannot concentrate urine. The water which reaches here, that water is not picked back up. Why is that not picked back up? This water was going to be picked up by the channels created by ADH. ADH is not there. Why is ADH not there? ADH could be not there because of two reasons. Either there could be a centralized problem that the pituitary and hypothalamus are not working very good for the ADH, or there could be a problem on the kidney cells that ADH is present but it cannot make its, it cannot do its action. So you could have nephrogenic problem or you could have a central problem, but the long story short, when the ADH is less here or ADH's action is less over here, more water would be lost. So if I come back here, what is going to happen? Water is going to be lost. Right? So dehydration would occur. But do we have enough amount of solutes going out as well? No. So what would happen is relative concentration of solutes is increasing. Correct? So we have hyperosmolar dehydration. Now how would that compensate on the ICF? The water from the ICF is going to move on this side to try to keep the osmolarity. So this would become a little bit bigger, and this, so this is what's going to happen. Hyperosmolar dehydration. Correct? Now we talked about various situations. So we can have isotonic fluid loss or fluid gain. That would only affect the ECF. Because there is no concentration change, nothing is going to happen to ICF. But we can also have hypertonic loss or gain or hypotonic loss or gain. These would affect this ICF side as well. So that concludes our lectures for the body fluid. We would continue with the renal in our next lectures. Thank you.